Around this time last year, we were again here. Okay, I wasn't here, since Atoma mentioned. I joined this organization last December. But we were here and we awarded 7, right? My boss said 7, so I can't argue. So we awarded the 7 innovators in this very space. And we are back here to hold ourselves accountable. How far have we gone? And how far can we go together so that next year we can even celebrate much more achievements? So Health Tech Hub Africa, we are Pan-African. Our mission is to support innovators and in a way that they can scale up faster, on one hand. On the other hand, we work with governments. How can we work with governments so they can also support these startups, especially in the aspect of scaling up in public health systems? So in that mission, we do it under 5 pillars, right? There's the policy, which is government again. There's acceleration, supporting these innovations and innovators. We have innovation challenges, which is again takes me back to last year when these innovators were awarded. We have a pillar on partnerships. Remember partnerships? Partnerships, because we believe for us to move together and move faster, we need partnerships. You remember partnerships? Partnerships. And the last pillar is standards and interoperability. How do we empower these innovators and innovations to be interoperable? We have a doctor here. Interoperability. Thank you. That word is I know I'm not the only person struggling with it, right? So yes, how do we enable these innovations to be able to plug into these national systems and vice versa, so we can, move faster and move together? So in the last, in that just 1 year, now let me get the numbers right. These 7 innovations, they have been able to reach nearly 1 million patients thanks to the hours they got here. Nearly 1 million patients. They reached nearly 3,000 health professionals, again in 1 year, and nearly 2,000 health facilities. In 1 year, just 7 innovations. Now imagine what we can do together as a collective if again we came together. Just display. Now, as a wrap up who knows this story? So this story is an exercise of blind people. In Rwanda, we do not use blind people. We say people with a disability of, not to offend them. So this elephant here, if you're blind, depending on where you touch, right, you interpret it your way. If you touch the tummy, you think, this is a rope. If you touch the tail, this is a rope. If you touch, for example, the trunk, you say, this could be a snake, And they're not wrong. But what's the message? The message is, it's also like us. The policymakers, they have their own way of interpreting digital health, You're in your own balloon, and then you have your interpretation. If you're in academia, you have how you see digital health. If you're a startup, an innovator, you have your own view. Then there is also the victim, the user, who is mostly just, ignored. You make policies, you innovate, but you also forget the user. So we are here because we think if now we came together, policymaker, academia, innovator, and think about the end user, we can have now the full correct view of what this elephant is. And not a oar, not a rope, not a spear, especially not a fan up there, So with that few or long remarks, allow me to welcome Dr. Camille Shoretire. Got it right? Almost right? He's the director and head of the Department of Health Planning, Research and Statistics at the Federal Ministry of Health, Nigeria. He is also the co-chair of our intergovernmental working group of this very health tech hub, Africa. So a very important person. Much respect. Welcome, sir.
Okay. Good afternoon. I know we've just had lunch, and from my knowledge of physiology, so much of the blood is around the stomach now, not in the brain. So, but still, if I say good afternoon, try to say good afternoon too, so that we know we are awake. Good afternoon, please. Thank you. Yes, thank you, Richard. We will discuss the interoperability later. It's nice to have you here at the 5th African Digital Health Summit and to have this Health Tech Hub Africa session. It's a partnership. He has introduced that. But as co-chair, my co-chair, Nigeria and Ethiopia, are co-chairs of this partnership to be able to drive governmental leadership in promoting digital health. Like I mentioned earlier today, there's nothing we can do to slow this down. So the only choice we have is to try and catch up. If we cannot catch up, try and move ahead with your imagination so that the guys, the intelligent, smart guys, can continue to develop, innovate, and make things happen for us. So, with what we've been able to do, let me acknowledge the works of the partners, Village Grow, Nosken, Patrick McGovern. USAID used to be a big part of this, JHPIEGO, and I remember last year we were still discussing and projecting many things with USAID, but the reality upon us today is that we need to forge ahead. Government needs to take more responsibilities, look into domestic financing, and encourage the startups. And particularly, message for the startups. Government is listening, we are watching, and we also want to urge you to please develop innovative way of communicating your ideas so that the important things that are developed, we don't miss them in terms of what we need to support, finance, and promote for the betterment of our health system. Elizabeth, you may need to be around here because so I don't lose I need to mention the important things before I start making people to laugh. All right. So we are here. We want to appreciate all the startups we've been able to support through the various activities we've done in the past. The 7 we have supported. I'm sure this time around, how many are we selecting? Atuma? Yes. Oh, 10. That's very good. I deserve a round of applause. From 7 to 10. That's a tremendous leap. So just to tell the would-be innovators and startups that there's still future, maybe next year we'll move to 100, right? Okay, 7 to 10. If I do quantitative analysis, that's not just 30% increase now. We may just be able to do that. So let me welcome you here and to tell you that HTHA Hub Africa is a strong partnership to make government's leadership to be harnessed fully in developing digital health system in Africa, promoting and also using it in a multi-sectoral system to improve the lives of our people. Thank you very much.
You did well. Thank you so much, Dr. Camille. At this point, so I've noted 3 things you said: domestic financing, government is listening, and innovators, you should look for ways to communicate your innovations so that government can buy in, right? So today we are here to listen to 2 companies that we supported from Nigeria. We have Helium Health as well as Emergency Response Africa. They'll make their presentations, and then we'll invite a panel that will be made up of government, development partners, the innovators, and most importantly, a person who has used this solution to save lives in Nigeria. So at this point, help me to welcome Ralph from Helium Health to make his presentation.
Thank you, Elizabeth. Hi, everyone. Good afternoon. Good afternoon. Yeah, it's great to be here again. My name is Ralph. I'm one of the co-founders, and I lead growth and expansion efforts at Helium Health. And around this time last year, we were awarded a grant by the Health Tech Hub Africa to develop and pilot a tool. So I'll be here to share the progress that we've made and how we've been able to use this solution in strengthening health systems within Delta states. Next slide. Yeah, so the name of the tool is called Helium Doc AI, and it's a risk stratification tool for HIV, tuberculosis, and diabetes. And the tool is born out of us trying to solve for some of the major causes of death in Nigeria, which is HIV, TB, and diabetes. And as you can see on the screen, the kind of metrics that we have in terms of the people living with this disease or who have exposure to it in some way, shape, or the other. And in Delta states where we had this pilot done, we have around 80,000 people living with HIV, and we have 21 to 40-year-old adults who are experiencing a high incidence of tuberculosis, and 14.1% of adolescents within the public school system are at increasing risk of having type 2 diabetes due to being overweight. And one of the things that is important to note is we've seen an increase in digital penetration in terms of mobile phone usage amongst the population that this is built for, which is between the ages, people within the ages of 21 to 40. Next slide. Yes, and in order for us to build this tool, we're able to take different approaches, and we're looking to strengthen the health-seeking behaviors of these individuals. So in developing it, we had literature reviews done, we had stakeholder reviews, questionnaires were developed, and we're able to design the algorithms. We liaise with different stakeholders within the government for us to get ethical approval. We had co-creation workshops. We also had user assessment and testing done, community outreaches, where we got feedback from the community, and we're able to also, use all of this feedback from the community and the stakeholders to strengthen the algorithm. And what we had at the end of the day was a risk stratification engine that uses voice AI and also text-based approach. So depending on the level of education or internet penetration that they have within that location, they had like two options. So it could be a self-assessment where you use a questionnaire through the text approach, or you could make a call and you have an AI who will speak with you called Anna, and it doesn't sound like an AI, but has like the Nigerian accent. You'd not even believe that it's an AI solution that is speaking to you. We also collected geolocation data for us to also have more data points for the study, and we also have teleconsultations enabled for those who would like to speak with a medical practitioner. Next. So in terms of the strategic insights from implementation, we were able to get results across different health systems levels. So in terms of policy alignment, we looked at the major diseases, which are HIV, TB, and diabetes amongst youths, through AI-based risk screening. We also got ethical approval to make sure that we are following laid down frameworks for this pilot study to be done. And for the decentralized access to healthcare, we were able to involve 75 communities. We had 3,000 youths reached, over 3,000 youths, and we had over 1,500 risk insights delivered via the stratification tool. So it was able to tell those who were high risk, medium risk, and also low risk. And we had 51 health facilities engaged who were involved in this study as well. And in terms of the design, it's human-centric in nature. We had over 80 stakeholders who were engaged within the medical community and also within the government as well. We had over 206 plus healthcare workers who were trained on how to use the platform. We had 83% of those who used the platform testify that it was super easy to use, even though they haven't had any sort of exposure to this kind of technology in the past. And we had UAT conducted just before deployment. Yeah, so for the sake of equity and accessibility, we had multiple pathways, so which could either be through the AI tool, or which is the voice AI, where you make a voice call, or it could be through the questionnaire. So we had those two options depending on connectivity. And we had over 2,000 voice AI calls were made, so both inbound and outbound. In some cases, due to network, the call could cut or get disconnected, and then the AI tool would make the call back to the individual who is trying to get stratified. And we also had over 1,500 plus text-based users reached who used the questionnaire in itself. And one of the things that the tool was able to surface is that high-risk behaviors was associated with unprotected sex, multiple partners, gender as well. Especially when you look at tuberculosis, when you look at diabetes, males are more prone to have diabetes based on the study than females. Alcohol use as well is also strongly associated with those who had tuberculosis. And then in terms of the public-private partnerships, we had strategic partnerships with the Delta State Ministry of Health to embed this solution within existing government systems in order for us to achieve scalability and also ownership by the government. And this is also leading to the deployment of potentially other solutions. So in conclusion, through the use of Helium Doc AI in the HTHA Innovation Challenge, we're able to explore how digital innovation such as this is able to support progress towards universal health coverage and help us build more resilient systems. Thank you.
Thank you so much, Raf. As Folake comes on stage, please note what he has mentioned about public-private partnerships. When we invite the government and development partner from UNICEF and formerly WHO, we'll speak more to that.
Okay, good afternoon, everybody. My name is Folake Owodunni. I'm the co-founder and CEO of Emergency Response Africa. While they put up the slides, Emergency Response Africa is a healthcare technology company, and our objective is to reduce the number of preventable deaths that happen from emergencies. So today I'm going to be talking about a project that we did in collaboration with the Ogun State Ministry of Health. I'm going to start by playing a quick 2-minute video, and then I'll talk through this project.
In rural communities like HTHA local government area, a woman's chance of dying during childbirth is 1 in 22, one of the highest rates in the world. The maternal mortality rate in Ogun State is currently 194 per 100,000. Although it is slightly high, it's still one of the better ones in Nigeria. So there's a wide body of research that shows that maternal mortality occurs due to a number of delays, 3 delays in particular. The delay in recognizing the need for care in a pregnant woman, the delay in reaching care once a decision has been made to seek it out, and then the delay on arrival at the healthcare facility and actually getting definitive care. So Emergency Response Africa, in collaboration with the Ogun State Ministry of Health, set out to address the second delay by providing access to transportation for women to get to emergency care when they needed it. Maternal mortality is something that we cannot continue to ignore in Nigeria. Nigeria contributes the third highest number, and simple interventions like the rural ambulance emergency transport system could make the difference for the Nigerian woman.
Thank you. All right, so we can just go straight to slide 3, please. Slide 3, please. Thank you. Next one. Fantastic, thank you. Okay, so you would have seen in the video that it started to talk about some of the problems that we face in Nigeria, and I'll just highlight a few. We have a very high rate of maternal mortality in the country, and it's estimated that 82,000 women, roughly 30% of global maternal deaths, are happening right here in Nigeria. Stillbirths and the deaths of newborns are really not far behind. Click again, please. Sorry, just bear with me. I thought I would have a clicker, so. So, you know, it said the research shows us that 50 to 75% of these deaths can actually be prevented if women had access to comprehensive emergency obstetric care. Unfortunately, there are many things that hinder that access, but transportation turns out to be one of the biggest barriers. In Ogun State, it's estimated that a lack of transportation to emergency care can actually account for up to 70% of the maternal deaths that happen. And so that's really the driver of the partnership that we got into with the Ogun State Ministry of Health. Next slide, please. So we came up with a solution that is essentially a community-based emergency transport program that's enabled by technology. And there are 4 key pillars of this program. First and foremost, and you wouldn't have seen it in that video, but it's this idea of community-based first responders. Individuals like you and I, not necessarily medical doctors or nurses, people already within the community who could be trained to provide a basic level of first aid and immediately facilitate transportation to a healthcare facility. The second piece is the technology, the use of simple mobile technology based on USSD and SMS to actually coordinate those community-based first responders. The third, of course, is transportation. One of the things that I'm sure many of us know in this room is that in Nigeria, we actually have a lot of ambulances that have been purchased by governments across the country. Unfortunately, most of them just sit there. They are either not used or they are being used for the wrong thing. For example, plantain. This is a true story. And so what we did was we partnered with the government to take those existing vehicles and combine them with the technology and the trained community first responders to create a coordinated system that could actually move the women from point A to point B. And then the last piece of the puzzle was a voucher system. One of the things we observed was that awareness and understanding of, and there's a lot of research on this, but awareness and understanding of how to recognize a maternal emergency is extremely low. So we needed to do certain things that would not only keep that information in front of them, but also enable the tracking of the emergencies that were being transported. And so that led to a voucher system. The last thing I'll just highlight with this system is that we actually opted at the request of the state to not only use it for emergency transportation, but also for non-emergency transportation to antenatal care. Because Ogun State, probably like a few other states, experienced low attendance, particularly low retention from the first antenatal care appointment to the 4th antenatal care appointment, and even lower retention to actually delivering in the healthcare facilities. And so this solution was adapted to not only address emergencies, but also help to address that problem. So we can go to the next slide. Next slide, please. Thank you. Okay, so very quickly, this was focused on one local government area within Ogun State, that's Odeda local government, where we trained 30 community-based first responders, took 10 tricycle ambulances and paired them 3-to-1 ratio to ensure that this was available 24/7. And then we had it partnered with one full-size standard ambulance to facilitate referrals out of the local community and into the secondary healthcare facilities. You can, one click, please. Thank you. So some of the things that happen in terms of practical, tangible deliverables. We were able to distribute about 535 vouchers, so a set of vouchers for antenatal care attendants and a set of vouchers for emergency obstetric care. We engaged in a series of community engagement activities, advocacy activities. You saw in the video the local leaders participated, had a huge buy-in into this program, and were able to reach about 1,600 people directly through those initiatives. Now, in terms of the numbers of women transported, we transported 611 women to their antenatal care visits, and 118 of those women were actually attending antenatal care for the first time. And for them, the reason they were able to finally attend was because they had access to this solution. So one click, please. Thank you. And so, when we then look at the impact on the women, And on the next couple of slides, I'll talk about the experience. But we had 41 successful live births during the project period and 0 deaths of those women. In fact, I believe we had 1 or 2 situations where the babies were actually born in transit, telling you the urgency of the situation. And a total of 113 emergency obstetric transports that were handled. Now, one thing we also observed was that, in as much as people were using this system for maternal health, there were other emergencies that occurred, and they actually started to use the system for other types of emergencies as well. One click, please. And so just to say that, Ogun State was so thrilled with the results of this pilot. It was a very short pilot, about 4 or 5 months, that they actually have gone on to sustain the program. So it was started off with funding, as described by Richard in the beginning, but it's something that the state has actually then taken on the responsibility of sustaining and is now scaling to 2 additional local governments with the highest maternal mortality rates. And we're actively pursuing a partnership with the federal level MAMI initiative to ensure that this can scale across. Next slide, please. So, just one more click. So just to say that, when we looked at the end of this project, we saw statistically significant increases across board in the antenatal care visits overall, in the new antenatal care enrollments, in the retention, like I mentioned, between the 1st and the 4th appointments, in the access to emergency obstetric care, and completed referrals between the 2 levels of care. And this is just a screenshot to show that the technology that was being used to coordinate this was extremely simple. We're not talking about anything fancy. We're talking about things that in a rural area where network challenges are a big problem can still aid the coordination. Next slide, please. So focusing very quickly on the experience of the people that were touched by this, I'll start with the pregnant mothers. One of the most consistent things that was shared was this idea of their mind being at rest, not having to worry that if suddenly they go into labor in the middle of the night, they don't have to think about walking long distances, which is the most common way that these women were getting to care before. They don't have to think about looking for a motorcycle, which was the second most common way. All they need to do is make a phone call and someone will come and pick them up. And one lady shares that, they were able to come and pick her up from her home and she was able to deliver her baby safely. The second lady shares the same thing. It has helped me reduce the stress of looking for a bike or walking when going to the healthcare facility. So it makes sense that these women were then able to complete more of their appointments and of course then deliver in the facility. Now from the perspective of the healthcare workers, the turnout from the women was massive and the community enjoyed the program because it eases their stress. And this particular worker talked about two emergency deliveries that happened within their program. One thing we thought was quite interesting was one of them said the husbands of these women usually come around to appreciate us. And they always try to redirect them that it's not us that are doing it, it's the government that's doing it. Next slide, please. And so finally, our community-based first responders, they're the ones that are actively involved in delivering this service. And I'm really excited and proud to have one of our community-based first responders here. He'll be joining the next panel to share about his experience directly. But you can see some of the comments. We were encouraged to work because we noticed that it's reduced the stress of the pregnant women and makes them come to the clinic. They talked about having learned so many skills. And these skills range from driving to actually understanding, well, how do you help, check somebody's blood pressure? How do you recognize the signs of a maternal emergency? How do you document accurately and capture data? Those are all skills that they had to learn as a part of this process. And it just, made them feel very proud of the role that they were able to play within their community. Next slide, please. So just help me click through so that all the bullet points show at once. So why this model works? First of all, click please, click. Thank you. Keep going till the end. So why the model works? First of all, it's really about using what already exists within the communities. I'm a big believer that in Nigeria we have everything we already need. It's a matter of utilizing it well. And so this was about taking things that were within the community and better utilizing them so that A, that investment doesn't waste, but B, people can actually see the benefit of the spending that their governments make. The second is that it really invested in building trust. It was essential from the beginning that the leaders of the communities were bought into the program and could actually help to drive the awareness and the adoption. Without their participation, none of what we were able to do would have been done. The third thing is that it was ultimately cheaper from the state's perspective, because suddenly you had a situation where, the cost to transport each woman was roughly 10 to 15,000 naira. When you think of a typical ambulance, it would cost you at least 50, maybe if it's really cheap, 45,000 naira per transport. So you had a significant cost savings from the state's part. And of course, it was validated by the state government itself, so much so that they were extending it to other local governments. But what I think for us was especially exciting is this idea of how you can take this and you can put it almost anywhere. What is it that you really need? You need willing people. You need the existing resources on ground. You need the capacity building, which is something that, the resources are there. This is something that can be readily scaled. And it doesn't matter whether you're in an urban area or in a rural, hard-to-reach area. This is something that scales. So last slide, please. And the slide has disappeared. Okay. All right. So just to conclude, at Emergency Response Africa, our focus is really on reducing the number of preventable deaths. And that applies across all types of emergencies, but we're especially interested in doing this for pregnant women. And so our goal is really to be able to scale this to reach 100,000 women across 10 different states in Nigeria. And through the MAMI program, we already know where those states are. We know where those priority local governments are. So it's really about doing this in a way that's as cost-effective as possible for the nation, has blended in and aligned with existing programs and policies, and ultimately we're looking for the partnerships that will work with us to be able to scale this up. So I want to say thank you for this opportunity, and please look forward to hearing from the community-based first responder.
Thank you so much, Folake. Please don't go. You're part of this panel. So health technology is working. 50 to 75% of deaths are preventable by providing access and quality emergency transport for women in their time of need. So the next session is a panel. I'm going to invite the two speakers. Raf, do you want to join the stage, please? I'm also going to invite our end user, Mr. Adebowale. Could you please join the stage? He's one of the people who was contributed to saving many women in the Ogun State, and he's been trained by the Emergency Response Africa. And then I'm going to invite Emmanuel Momanyi from Vilgro Africa. Vilgro Africa is an investor as well as an ecosystem builder. They're contributing to helping startups in their business strategy, and he's going to talk more on that. And I'm going to invite Dr. Camille from the Federal Ministry of Health, kindly join the stage, as well as Dr. Sani from UNICEF. He's a digital health strategist, formerly with WHO. And this beautiful panel here is going to help us understand why, if digital health solutions are working, why then are many of them dying at the pilot stage? Why are they not scaling? And then I will ask government as well as our development partner to tell us more about actions that governments can take, partners can take to address this problem. So I'll start with you, Mr. Adebowale, and ask you to kindly share your personal experience. What experience have you had as you were using emergency responses solution to save lives? Thank you.
Good afternoon, my people. I'm greeting you, sir and ma. Good afternoon, ma and sir. My name is Adelaja Adebawale Razak. I'm representing Ogun State ambulance driver. Good afternoon once again. It's a great privilege for me being among you today, and I'm really appreciate it. I thank the organizer and coordinators. My point goes, share personal, practical, instant use the emergency Africa solution. Wow, lovely question. Before, I'm not on that line because I'm representing Kurutola Ventures at NAPC in Ibadan. But when I got to the other side, which is Orile area, after some months, I received a message about the launching community first responders, and I was so loved when I heard it. I went for 3 days training. During that 3 days training, they teach us how to know some things pertaining to health. Even in my house is helping me. Moving up and down in community is helping us. Some signs that are very dangerous in area that we are not looking at it. We just take it lightly and it kills our people. We are teach there, then they give us another exam before they pick us, because it's not everybody to pick. We are selected. Glory be to Almighty, I started serving community basic first responders in other local government in Ogun State. For past 10 months, started this thing. ERA was now introduced their policy into our community in Odeda. When they introduced this thing, before in our community in Odeda, we are having an issue on our pregnancy woman. Moving up and down, especially moving to the health centers, facilities, is very difficult for them. Apart that, road accident or bike accident, to rush them to center or any maternity place is very difficult. Most are dead because of that little things. Once the area start the program, moving up and down of emergency, it's very easier for a pregnancy woman because they believe that once they give us call, we will present. I could remember the case they called me around 1:30 to 1:30 to 2 p.m. That's midnight. I received a call saying that he needs us very emergency. I'm trying to ask what is going on. The man is telling me that his wife having birth at home, but the placenta is not coming out. What should I do? I say, okay, don't worry. The man still provoked by saying, Mr. Man, please calm down. Next 10 minutes, I'll be there. And I try my best. God give me the chance. When I get there, I ask for a neighbor that will assist me to put the woman on stress bed with the baby. On my way to facilities, premium centers, I gave one of my nurses calls that I'm on my way for emergency. So when we get there, they attend to the woman. And the matron come immediately that this case cannot stay here because this is Premier X Center. I have to take her to General Hospital at Odeda. And if you convert the time, it's almost going to 3. And from my place to the Odeda General Hospital, it will take me 40 minutes. I don't have option because that's what I signed for. I took the woman immediately with the baby to Odeda without waiting for the woman's husband. Before the woman's husband come to Odeda, glory be to Almighty, the woman was treated inside that ambulance delivering successfully. So I was so impressed. Then I know that this is not a joke, this is not a play work. This is good work saving life. So I am really appreciated. Anywhere I move in an environment, They're always calling me Okoloyu. Due to all their day, especially clinic day, I will make myself available. If you know that I said I'm working at NAPZ, but that very day, I will make it available. But remaining days, I will leave it for my others colleague. So even in community, if I'm working or if I'm going somewhere, they'll be calling me, Okoloya, I have headache. Don't say that you have headache. Go to health center. Because I know the meaning. Even there was a slang that we are using among my colleagues, because I told my people that anywhere you find me, just call me CB Ever. And if they call me CB Ever, I will tell them, saving lives. Yes, that's our motto. CB Ever, saving lives. So anywhere in Odeda, with our uniform, once you see them, or anybody I know without uniform, you will call CBFR, saving life. I know that something wants to happen there. I will go there. Hope there is no problem. I will challenge them. If you see any pregnant woman moving up and down in my community, I will ask. I will stop that pregnant woman. Wait. Are you going for your clinic? If she said no, I will give her my number. Call me on Wednesday. I will come and pick you by myself. Why you're not going to say, I'm busy? Because most of them, they like to work, and the work they're doing there is Gary. So they don't have time. Going to bush, go and getting cassava, slicing it. That's their work. They don't have time. It is we that we are going there to pick them. Most of them don't know that we are after their life, and some know. So I'm really appreciate. I'm really, really appreciate. Thank you very much. My name is Guzman Adela Jadibawale. Thank you.
We can do better. I mean, that's amazing. Thank you so much. And I'm sure it wasn't very easy to convince him to use the solution. In a minute, please, could you please share your experience in how you managed to convince him to use your solution?
So I think the maybe joy that we have as Emergency Response Africa is that Nigerians, we generally do want to help. We genuinely desire to help other people, especially people within our community. So from that perspective, it wasn't really that we had to convince them to use the solution. It was really about helping people to understand, okay, this is what is at stake. We've already experienced the deaths. We already know somebody who knows somebody who knows somebody that has lost someone. And what we're saying is, here's a solution, a simple solution that if it's in place can actually prevent that. So I think that was kind of the biggest thing really, is that education. I won't say it was even more about convincing. Now, when we talk about overcoming some of the daily challenges or the daily issues with the system, yes, that required a lot more intention, and that's where the training came in. So training in using the solution, training in capturing the data, but also accountability. So being able to, I think it was the previous speaker that said, whatever you don't measure fails, or something like that. So being able to make sure that those accountability systems were in place, so that daily we're tracking who's been transported, who called, what were the issues, how do we learn from that, how do we improve the system.
Thank you. So it's training, and that is one of the things that makes or breaks adoption of solutions. Now, Raf, they are also in Kenya, and other startups are struggling to scale. So kindly share with us in a minute, what are some of the ways that you employed for Helium Health to scale beyond Nigeria?
Scaling is not a very easy subject. But one of the things that I would mention is local context, because Africa is very diverse. In fact, Nigeria, for example, is very diverse in itself. We speak multiple languages. We have different cultures embedded within the same country. By the time you're looking at the entire continent, and a lot of narratives, right? Africa from the outside is typically, referred to almost like a country, but it's not a country. It's different countries, all we have all come together to form a continent, and with different currencies, different languages, different cultures, um, and even different attitude towards technology as well. So when we scale to other regions, we do not um, take what we have as is into that local context. We always look at what already works in there, how did those technologies tend to work, how were they able to gain adoption, and then we are able to look at what we can adopt and implement within our own deployment methodologies, and through that we're able to solve for that. And it varies across the different products we've been able to take out of Nigeria to other countries. Helium credits, for example, which is financing products within Nigeria, will give loans to healthcare facilities. The way it operates within Nigeria, it's not the same way it operates within the Kenyan market. The attitude is totally different, and we have to solve for that in a different manner. Thank you.
Thank you, Raf. Emmanuel, you were shaking your head as he was speaking, and being an ecosystem builder from Vilgro, Africa, I know you have a lot of insight as to what set these companies apart, and also what collaboration means within the ecosystem to ensure that they have an enabling environment to make them who they are. Do you want to speak about that, please?
Yeah. Hello, everyone. I know I'm seeing the gentleman standing there, and I know that means we are out of time. But just very quickly, I could speak a lot of things that actually set them apart. But the main thing is being able to align themselves with different priorities for the different different governments and the different markets they're operating in. So Richard did mention we had 7 companies. And if you look at the 7 of them, that's from Rwanda, Kenya, and Nigeria, they all prioritized or looked at areas that the existing governments actually were focusing on. So these are areas that were identified, were either in the national strategies for health by the different ministries. So Helium did mention about HIV, TB, and diabetes. And if you look at the strategies for the governments, the state governments, including emergency response, like it was a priority for the government of that state, and that's why they're actually even willing to pay for it. And so it's very differentiating when you have an existing government entity that is actually willing to work with you. Even right now, as we're selecting the 10 for this year, it's one of the things that we're looking at. So especially those that already have existing collaborations or existing partnerships with governments, or those that have the potential to close partnerships with government, would then stand a chance to scale to the public sector. Again, what can we do to reduce the barriers to scale? I would say maybe 2 things. Number one, all of us, especially the policymakers and the wonderful gentleman on my left, at times, I feel like government oftentimes creates policies on their own. Granted, there are governments that actually involve other stakeholders. And maybe stakeholders that are involved are not necessarily all the stakeholders, especially in the startup ecosystem. So for example, only an investor will tell you how a policy affects them as an investor. If you took an entrepreneur to give their views are probably not going to touch on what the investor thinks, right? And again, only a startup will tell you how a certain policy affects them. So imagine bringing all of them on the table to then collaboratively create those policies, then enables you to create a more enabling environment. But beyond that, I think the other thing is we need to change our mindset as Africans. So, for example, the investment space is full of capital from the West. Perhaps it's time that we also looked at our own local solutions as investable solutions. And maybe you and I put money into startups, right? you can, instead of putting money in a money market fund, perhaps maybe we need to create a mechanism of pulling funds from ourselves to invest in our own startup, so that we don't have to rely on investors from the West to put money into our startups. I think I'll stop there because of time.
Thank you. And I love that stop. You said we put money to our solutions, for Africa by Africans. Dr. Sani, kindly talk us through the changing funding landscape. How can we as Africans start working on our domestic financing so that we can have more solutions addressing public health challenges in Africa?
Thank you so much, and I'm happy to be part of this plenary. And let me also say that I'll be wearing two hats in this plenary. One, the hat of the WHO, because I'm standing for Derek, then also the hat of UNICEF, which still falls under the UN. So before going to talking about the changing financial landscape, let me first of all, talk about a few things that just come up in this plenary from the end user that spoke with so much passion. Thanks so much for what you're doing. It's most appreciated. And from Hello Health, from you, ma'am, and from you, Oga. One thing coming out clearly is this. The innovative digital solution has opportunities to strengthen service delivery. However, I'm happy I'm sitting next to the government. We, as UN, work with the government. We serve the government, and we don't do anything without the government. As part of what we do, we develop what is called CPD, Country Program Development, sitting with the government on the table to prioritize what government is prioritizing, what they want to address, their pain points. And of course, that goes back, first of all, starting to work with them to develop the strategies. The strategies inform what happens in the country for that year. The National Digital Health Strategy in Nigeria, I know we start with government at some point to get those developed. And also we ensure we, through the government convening power, get partners on the table to come together to discuss around implementation, talking about operationalization of that strategy. Those happens. Now, of course, part of what we do is to now see how we discuss with governments to see how government can own this through, diplomatic discussions and policy, to see how governments begin to prioritize allocation to digital health programs. Of course, everyone here knows that Nigeria, unfortunately, is yet to meet that Abuja declaration of 15% allocation to health. Even as that, the allocation going to digital health itself is getting narrower every day, and for which we will continue to sit with government. And I'm happy I'm sitting with these organs to me here, to see how they can, drive this. I know it's not what he can do alone, but then through continuous, discussion and dialogue, we see how we can ensure government continue to increase funding to digital health programs, not the health as a whole, but digital now. Given the changing landscape, of course, it becomes so important for us to, prioritize more allocation to digital health, or to health, specifically to digital health. And part of what we are doing as UN agencies have been, of course, what is going on in the global landscape, ODA cuts here and there, layoffs here and there. So we are taking a step backwards. We are beginning to deprioritize what we, support the government. And also internally, we are beginning to vigorously pursue strategic funding for our programs. In the Hall A, where I presented earlier today, I made mention about a meeting coming up in Beijing next week, where I'm speaking to the Asian global funders, and I'm presenting to see how I can get some money for digital health in the Asia region. And I believe such strategic discussions should also be happening in Africa, where we are now pitching, private donors, philanthropists, and of course, rich governments to see how they can put some more money on the table for us. Currently, the program I'm working on, which is actually paying my salary, is from the government of Japan. And this is a 4 years program, and it's coming to an end. So I'm happy to, speak with all the Asian governments coming together next week in Beijing to see how we can get money to continue to support the digital innovation across the Asian countries. And part of, what that means is developing an investment case, which after my presentation next week, easily pitch to, participants of that high-level forum, and then to see how I've talked about, meeting with government to see how they can improve on domestic financing of digital health innovations. But then the strategic partnership, the other of my colleagues talked about the public-private involvement. That is also critical. We're also exploring that option. But internally, what we are prioritizing now is, as UN, being a little strategic, pitching philanthropists, donors, and other public partners to see how they can increase funding of our programs so that we can continue to provide that support to governments. Without that, we can't do nothing. Thanks.
Thank you so much, Dr. Sani. Dr. Camille, everyone is happy to have government here. And there's a call for government to increase domestic funding for digital health. And also, without government, there's no sustainability. We'd like you to reaffirm your commitment towards digital health. There's some progress you've made in Nigeria around this area. Do you want to speak about that? You're hosting us as Africa. Speak about that, please.
Thank you very much. Let me congratulate the earlier speakers. Adelaja, thank you. That's inspirational. Keep doing it. We appreciate that. Helium Doc. We've just had defunding due to the many activities the USG pulled out of. Perhaps the product you've just displayed could find a way of relieving some of the difficulties that the ATM is battling with. And thank you, Folake, for that excellent proof of concept, I would say. And I'm happy Algon representative is in the hall. You may need to still talk to them. If local governments, by local governments, can adopt this, we don't necessarily have to wait for 350,000 USD. We can start local government by local government and gradually, especially the identified 172 local governments that have high burden of maternal and child mortality in the country. So, and also want to make this offer, if I forget, the next Council on Health taking place in Cross River. Please, maybe you work on that video. We will use it at intervals for the honorable commissioners during the meeting. That I can guarantee you. For us, it's still about 15% spending on health. Whether you spend more than 15 or you spend more than less than 15, the problem is the health problems of your system, of your country, of your people needs to be addressed head-on. And in quantifying the amount we spend is a bit difficult. I know UNFPA will give us one formula or the other. For instance, in the country now, Ministry of Water Resources is helping with water supplies. These are some of the things our PHCs need to make things happen. Before now, it is Ministry of Health that is expected to provide water in the PHC and provide electricity. So now we are engaging Ministry of Power to please electrify our PHCs. So that, and these are the costs that when you put together can actually take us up to 15%. But what is more important is what are the people getting the right services to save their lives, to reduce physical pain, to reduce financial pain, and also producing good health for them. That's the current government is committed. Spending on digital health system follows the same trajectory. Startups are doing excellently well without government support. These products are coming up. Many of our federal tertiary health institutions, about 80 of them, at least 60 of them are using one solution or the other. Not from government, but with government support that they should patronize these different products. And many of them are doing well, you know. Some are changing from one to the other, and this is where our support comes in. When we patronize these locally developed softwares or AMR solutions, we are also supporting more innovation in those areas. Like Folake demonstrated, simple solution using 3310. That's the phone now. It doesn't have WhatsApp. Yes. And we can get the ambulance driver to come, pick the woman in the rural, and get it done. So, like I mentioned earlier today, government has no choice. These innovations are happening with government or without government. So the only choice we have is to embrace what we are developing that has been proven to work, to lessen the burden of our health system by increasing the speed of attention, speed of service delivery, quality of care, and also making sure that the data is seen real time and acted upon. Because data is useless on its own if it's not made use of. We are using data for decision making, and we still welcome more innovative solutions in digital health to help us. You know, some of us have power to imagine. Some can design. One of the things the physiotherapist mentioned, sorry, I forgot her name, the Linus US or something like that, the first presenter. Some can imagine, some can design, some can fund. We need to bring all of them to the table. When you imagine, you tell the person who can develop, I'm thinking we could do this, we could do that. And then the person better understand it and do something about it. Government is supporting that. And let me take you to what we are doing in the Federal Ministry of Communication, Innovation and Digital Economy. Because I don't need to tell you about the minister. He's a tech-savvy expert, and he's bringing his experience and what he's doing in the Ministry of Communication to impact on other sectors. As we speak now, the fiber optic cables owned by government, of course in PPP, will be passing through all areas where our major hospitals are located. This is also to boost. We've been talking about interoperability. When network is epileptic, interoperability becomes frustrating. You want to get something across to another facility or to another state or to another system, is not happening. Government is committed to this. We are funding digitization of our system. We are funding digitization of our health facilities and our data collection system. And for some of you that have visited my office, if you come now, it's been completely digitized. And real time, you see what is happening in every local government in terms of data input and all that. And we are able to see red color or green color or yellow or amber. We know something is happening here and all that. And we intend to do that, encourage other states to have that. Commissioners of health should have a dashboard to see what is happening in their various local governments, how many people have died overnight, you know. This is what innovations in the digital health can bring to the fore for everybody to understand. And before I round up, community ownership is key to the survival of such ambulance system that Folake demonstrated. This is what each and every one of us, I see the surprise on everybody's faces, especially those that do not have the privilege of having grown up in the village. Those of us that have lived in the village, we know what is happening there. People want to help themselves, but they are not that empowered. People want to act why wisely, but they don't have information. And people like Adelaja wants to help. There's no opportunity to display the help. So these are the various areas we need to continue to explore to bring up ideas that are implementable for government to act. At the beginning, it may look expensive, but actually, it's not expensive at the end of the day. More investment, people are healthy, then you don't talk about going to hospital to treat malaria again. You know, these are the things we need to do. But I'll tell you, in terms of commitment of government, this particular government is committed. We are working with NIDA, that's our National Institute for Technology Development Agency, and Health is working with them. We have a privatized company owned by government, but with privately run management, the Galaxy Backbone. We are pushing them to do more, to give us hosting capacity and opportunities for our data to be in and for everybody to have access at next to nothing amount. This is being done by government, and we'll continue to also leverage on the information. Like I mentioned, proof of concept. Tell us how it has worked. Tell us where it has worked so that government can run with it. And even patronize you so that whatever you have invested in proving this concept, you can recoup it over time with government patronage and support. I think I should stop there so that I don't talk too much. Thank you.
Thank you so much, Dr. Kamila. Thank you so much. You said government support, strategic domestic funding. We should invest in our solutions, access, quality, government partnership, understand the landscape you want to scale to, and community actually recognizes digital health implementation. Don't you think that's an amazing panel? Kindly let's clap for them as we invite our last speaker to wrap up the session, Justina, who is the Senior Principal Officer. As they plan to take a photo, she's the Principal Scientific Officer at the Department of Health and Planning, Research and Statistics at the Federal Ministry of Health, Nigeria, to wrap up the session. Clap for them as they take the photos of the kids.
Okay. Good evening, everybody. I want to thank all presenters. My name is Justina Okwedo from the Federal Ministry of Health. I want to really thank all the presenters, the panelists, and all our participants, both from different countries. Most of us are here from different African countries. You will agree with me that this meeting has actually met the objectives of this 5th African Digital Health Summit. By being action-oriented, it has also built on the outcomes of the previous 2 health summits, especially. It has also advanced regional collaboration, because most of us here are from different African regions. It has also strengthened our capacity, and it has also promoted practical innovation in a way to better integrate health tech into our public health systems, Africa public health systems. Some key takeaways we have taken from the presentation from the different presenters. We saw from the emergency response. We also heard from the helium health and the other presenters. You people have made insightful contribution, and we really appreciate this. So from the session, some key takeaways we can take is that there is need for alignment, for us to align our strategies with national priorities. there is need for us to also align and promote local content with what is already existing in our individual states, in our individual country, in our individual community. So we saw the examples that we have given, and the need for us to also scale up what is piloted and it has been tested and proved, for us to scale it up to other states or to other communities and our country. So I really want to thank you all. And I don't know if there's any point I'm missing now, just to say thank you very much for this wonderful session. And we hope to see you also tomorrow. Thank you.
From Health Tech Hub Africa, we are grateful for everyone who joined this session. Thank you so much.
Thank you very much. We're going to go straight into the technical session. Unfortunately, the time has been gravely eaten into, but we'll do